Welcome back to our second portion of Hispanic Heritage Month virtual town hall meeting on opioids, substance use disorders, and mental health. We're thrilled, pleased to have back with us our ORN, Opioid Response Network consultant, Dr. Hector Colon Rivera, again with us. This is our fourth year, and I think we've done 20 shows by now. So we have a good foundation. And I'd like to welcome, Paulina, are we ready to welcome Mr. Mac?
Should I? Yes, we are ready.
Gracias.
Mr. Mac.
Hola.
Hola. Good afternoon. Good afternoon. And hello, everyone. I'm Al McFarlane. I want to do a special welcome to you. Typically, I do this program. I open it with greetings to the audiences here, announcing the program as The Conversation with Al McFarlane. Today is special. It's Conversation with Al McFarlane and Carmen Robles. And special indeed because we are friends, we are connected, joined at the hip, pioneers, fighters, advocates for our people, Latino, African, Afro-Latino, actually human beings, our people, humanity. And so with that spirit and that caveat, we walk every day seeking healing and health for our people in particular. We recognize that institutions and political processes have disadvantaged and marginalized. And we believe that our mission as communicators and as educators and as workers is to sort of level the playing field and to ring the alarm, to encourage ourselves and the world to pay attention to our health and to reframe how we see ourselves as opposed to being described as the problem. We believe it's important to describe ourselves as the solution. So this is about both being healed and being a healer. And that's a critical conversation now that we're talking about the impact, the scourge of opioids, the epidemic of health challenges, mental health challenges, physical health challenges. So with that, Carmen, I'm so glad to be here, so glad to share the platforms that I bring to this conversation, that we name them. And it's critically, I think, important to acknowledge that we're streaming live to the YouTube page and Facebook page of the Black Press of America, National Newspaper Publishers Association. And the Black Press of America has maintained a historic and powerful alliance with the Hispanic Press of America. We know that together we are bigger, better, stronger, and more impactful and powerful. So this conversation and this venue both reflect the power of cooperation, collaboration, shared value, shared opportunity, shared vision. Also, we are engaging the digital platforms of my newspaper, Insight News, our YouTube page, our Facebook page, also our LinkedIn, and our Twitter pages. So I want to invite anybody who's joining us by any of those venues to join the conversation. to pay attention. Tell your friends that we're having this important multicultural, multilingual, bilingual conversation. We're talking about healing and health, a response to the opioid challenges in our communities. With that, Carmen, let me turn it back over to you. I'm going to be a listener and a supporter, and let's have this wonderful,
Well, no, you're not. No, you're
these great
not. You're
guests
not going to
that
be a
are assembled here.
listener.
Paulina,
You're
how
not
are
going
you?
to be a listener and supporter. Go ahead.
Yes. Hello, Mr. Mac. Let me introduce you to the guests, to the important guests we have here. We have two professors from the Metro State University, Professor Theresa Levin and Kevin Spadin. Yes.
Hello.
We have two doctors from the medical field, Dr. Morales and Dr. Hector Colon Rivera. Yes. And I think I'm missing someone else.
Are we?
Yes.
Oh,
Father
Elizabeth.
Jose Antonio Machado. Yes, of
Oh,
course.
hijo José de Antonio.
Well, mucho gusto, señores. Tanto me gusta ser con ustedes, visitar con ustedes ahora. Y creo que tenemos una conversación importante y significante y me gusta mucho.
Sí, porque usted es cubano y tiene raíces cubanas. And
Claro.
luckily you have me around to remind you. And I've been a writer. I used to do teletyping or whatever for Mr. McFarlane. Y también para la prensa con Mario Duarte. And so Mr. McFarlane has been very generous in allowing me to learn his multimedia experiences, but most importantly, to be able to connect us con Conversaciones de Salud, which started with Mr. McFarlane with Conversaciones con Al McFarlane y Carmen Robles. So it's a great deep honor. And Mr. Mack, I'd like you to please interview our guests because this is such an important topic. And you're in it. Diana Hawkins, who I know is in our audience, is in it.
Sure.
We have a list of wonderful guests from all over. And if you could please facilitate
Absolutely.
this. Muchísimas gracias.
Glad to. Well, let me go back to my friend and the person that I have learned so much from in our previous conversations, Dr. Hector Colon Rivera. And doctor, for this part of the program, you may have done this already in the first hour, but for the new audiences that we're engaging now, let me ask you to set the stage, to give the background. Why is it that we have to pay extra attention right now to the challenge of the opioid epidemic, and how can we manage and navigate and move our community, our families towards health? So Dr. Colon Rivera.
Yeah, I mean, that's a tough question, and require months of discussion, but I'm gonna do my best in a few minutes. So I think a lot is happening, right? Not only the pandemic continues, we have other pandemics coming up, and we will have more in the future. We still need to stay safe on those, but the system is going through some changes. I mean, we're going through a difficult economic now. Federal rates increasing every month. We have inflation coming up. Continues to go up. Health services have been limited in terms of staff. We have been losing staff due to sickness or because they are overwhelmed. There's a lot of burnout in the physicians, nurse practitioners, social workers, anyone that deals with patients or customer or clients. I mean, anyone who deal with human beings is feeling burnt out because they already have their own situation going at home, personally, and plus dealing with or trying to help others. So all of this is, it's a perfect storm. And we have been dealing with this for years. It's not, the opioid epidemic didn't start yesterday. It didn't start back in 2013 when opioid overdoses spiked in the US. It started back in the 90s. I mean, this is just a multiple of events collecting for the past 20, 30 years now. And now we are in a momentum of the economic kind of crashing and just holding what it can. And and all the social determinants of health are in the surface, right? We're dealing with increases prices of rent, transportation issues. We're dealing with education. You know, our kids going back to school after 3 years of probably hybrid system or just school through the computers, cyber schooling, people trying to go back to work or trying to get a better job with this inflation going up of 8 point something percent, you know, in the same salary that they were working 4 years ago. So doesn't match the needs that they have now. So why is it important to talk about opioid epidemic? I mean, we know mental illness is, I mean, depression, anxiety, trauma after trauma. We know that people that use substances, as a mental illness precede that substance use. People try to treat their symptoms with medication, even, you know, medication prescribed. They can overuse the medication on the street, you know, illicit substances. They're just trying to do their best at some time and start experimenting, then abusing, then create a substance disorder. And that's what we don't want, right? You want to be working on teams, work on collaborations, on coalitions. So we prevent this substance disorder from happening. We take it, you know, from the beginning when people are experimenting because they need to perform better or work more hours or take care of their kids or take care of others or themselves, and they get in that trap of using this type of drugs. And then we have a substance disorder, which is detrimental for their health, but also for society in general. So the tension has been there. I think we have less staff to take care of these people and ourselves. So the workforce and this is a big problem we're having right now.
Let me take a minute. Thank you, Dr. Colon Rivera, and give more background on you. Dr. Colon Rivera is a distinguished general, adolescent, and addiction psychiatrist of the Pennsylvania medical community. He's got a broad experience in community-based programs, emphasis on those that help increase access to assisted medical treatments for patients with substance use disorder. Dr. Colon Rivera is the medical director of the Asociación Puerto Riqueños en Marcha, Inc. Behavioral Health Program. It's a nonprofit organization dedicated to improving the quality of life of Hispanic communities through direct behavior and substance use disorder services in the Philadelphia region. The organization has functions related to education, health, human services, and community, foster homes, and economic development. He's also an attending telemedicine physician who has participated in a grant funded by the National Institute of Health, Environmental Influences on Child Health Outcomes. It's called ECHO, I think, initiative at Western Psychiatric Institute and Clinic, and at the UPMC. Part of a team working on emergency community programs to increase rural access to medication-assisted treatments for patients with substance use disorders. A lot more that I can share, but that gives you an idea of the context, the background that Dr. Colon Rivera is bringing to the contribution, leadership, and service he brings to our community. I want to next bring in another one of our esteemed physicians, Dr. Alfonso Morales. Dr. Morales, let me introduce you later, but have you read your bio later, but have you start with your voice and your comments, your thoughts, top of line. Good afternoon.
Good afternoon.
Buenas tardes.
Buenas tardes. Hi, everybody. So thank you for having me. It's I agree with Dr. Colon. It's a storm that's been going on for a number of years, since the 1990s. There is, one of the issues that we see, and I tell people right now, is we have two major epidemics going on in our young people. I mean, never, and I tell this to my patients too, never in the history of humankind have we had the technology and the longevity that we have nowadays. But the problematic thing is that the young people our younger generations are living for less years. They have a lower longevity than their parents because of two major epidemics. One is the obesity epidemic and the drug epidemic. And that's what's killing our young people. The drug epidemic comes from the mental health crisis that we have. It's I sometimes account we don't have so much of a drug crisis as a mental health crisis because people are using drugs to cope. And we have a shortage of psychiatrists. We have a shortage of mental health professionals to help and assist. And so patients, yes, they go to the streets and self-treat, or they experiment, or in the days when, I do pain and addiction, that's my background. We were, back in the day, it was a fifth vital sign, pain. People got pain, opioids, and then all of a sudden they said, well, these people are getting addicted and they're overdosing and so on. But now the pendulum of the CDC says, well, maybe we shouldn't take them off these opiates so quickly. It's harm reduction. Because once you take them off the opiates, now they're suicidal. Or they go to the street. So there's a lot of stigma in the way this has been. They've been basically going after the cartels or the drugs. It's a drug war, or it's more about how about we take care of us as a community. How do we prevent this from what's going on? Why do we have a mental health crisis? Is it because we have poor connections, social connections? Do we have? There's communities in Mexico where people live very close knit, and the use of drugs and alcohol is much less, even though they have poverty. And so here we're the wealthiest country, and we have so much mental health. Why? Because we live disconnected. We don't have dinner with our kids anymore. We don't have. It's one of the things that I think we could prevent addiction by being more connected and checking on our kids. So it's a major problem. The other problem I have as a physician is with the availability of buprenorphine. So I may give, as a pain physician, I may say, you have the risk of addiction, and I'm going to give you buprenorphine for pain, which helps for chronic pain. Well, the insurance company comes back at me and says, wait a minute, this is too expensive, we won't cover it. Have you tried morphine? Have you tried fentanyl? And I'm saying, are you kidding me? These are the meds we don't want them to be on. Why can't we use a medication that's more effective for chronic pain that helps, and they won't get addicted to it? So it's they might be dependent on it, but they won't need to escalate on it. So those are the battles we fight. And so any doctor will say, who's seeing a family physician, 20, 30 patients a day, or 20, depending on how many people they're seeing, they're going to say, well, I'll just write you that oxycodone because I'm not going to deal with the prior authorization. So there's barriers at different places. Barriers institution, barriers families with stigma, barriers with physicians too. There's physicians who have stigma for the addicts. Instead of calling them patients with substance use disorder, we call them addicts. That's already stigmatizing the patient. So I think there's several barriers that we can all try to attack by education. I think education is main here. Why aren't we using more medication-assisted treatment? Well, I sometimes encounter outpatient treatment centers where they just get them off the streets again, and there's no continuity of care. I, as a primary care physician, I'm all about chronic care. Addiction is a chronic disease. It's not just, hey, wait, they went to Hazelden or Betty Ford for 2 weeks, 3 weeks, a month, and then they're out. No, we have to follow them after that. I need follow-up. I need to have them see, try to evaluate them, do we do a wellness protocol, do vaccines, make sure their status is correct, their nutrition is correct, and then help them throughout the process to maintain sober with medication-assisted treatment. So, and sometimes these places don't believe in medication-assisted treatment and say, no, let's get them off these meds, and Suboxone taper, quick taper, and then now they're in withdrawals or they're triggering, and they go to the street. So those are the stories that sometimes are not being told by the media, and that it's very important that we make this our priority to educate the community and our politicians about what's going on.
Well, I'm so grateful for you, Dr. Morales, for your both wisdom, leadership, and the knowledge you bring. Let me tell our viewers and listeners that Dr. Alfonso Morales is the medical director of Revive MD in St. Paul. He specializes in pain medicine. He's a diplomat of the American Board of Pain Medicine and a member of the American Academy of Pain Medicine, American Pain Society, and International Association for the Study of Pain. And he's been a guest speaker at a number of medical conventions and conferences. He's got a passion for educating physicians as well as patients in the multimodal pain approach to the management of pain. You've heard a little of that to begin with. We'll come back to that. Let me bring two other of our guests in, and then we'll come back around and broaden the conversation. I'm Al McFarlane, and I'm honored to be here with my colleague, Carmen Robles, in the special town hall on the impact of opioid in our community. This is the 4th annual Minnesota Hispanic Heritage Month Opioid SUD Mental Health Town Hall meeting. I'm so honored to be a part of that, and honored to bring in the Black Press of America into this conversation in our partnership with the Hispanic Latino community. And as Carmen mentioned, I say that as a member of both worlds. I am Cuban, Afro-Cuban, and study, and I thank Carmen for pushing me and pulling me into acknowledging and living in that aspect of my own genealogy. Well, let me bring in two other guests for the program before we open the conversation up. Professor Teresa Libby is here. She is the chair of the graduate program for human services, I believe, at Metro State University Human Services Program, and also Kevin Spalding is here. He's Associate Professor of Human Services. Let me bring you both in together and have you make an open statement, sort of giving the background and what the viewpoint and strategy of your institution and your personal professional initiative in explaining, understanding, and mitigating the impact of opioid in the community in general, our communities in particular. Let me go to you first, Professor Libby.
Great, thank you so much. Just so pleased to be here today for myself and for Metro State. So I am the chair of the Human Services Department and the founder and former director of our graduate program, the Master of Science in Co-occurring Disorders Recovery Counseling. So our job, and I'm still faculty in that program, and our job there is to train the next generation of master's level therapists prepared to work with people with substance use and mental health disorders, and people who experience both. So I appreciate the what's been said about what opioid use looks like and all the consequences that attend it, like what that looks like today, and that today is it's not an anomaly, right? Talked about since the 1990s when we started seeing this escalation. And of course, even before then, opioids were a consistent problem for generations in the U.S. And so it was something that didn't get the attention that it deserved, and there are various reasons why it started getting more attention starting in the 90s as deaths started to escalate. But one of the factors there I think it's important to point out is that some of the neglect that was happening in pre-mid 90s had to do with who was most affected by opioid use disorders, and that included the most affected people were those in Black and brown communities, and as long as sort of addictions and deaths remained at a certain level, I guess it just wasn't considered that big a deal. Obviously some of us were out there trying to provide services, including methadone maintenance programs, various kinds of counseling programs. But the need was just not being addressed the way that it needed to be. And the reality is that as a what we're now calling the opioid epidemic, in its early days, like what drew a lot of attention to it is that now we weren't just looking at Black and brown communities. We start seeing all these news stories about young white people dying of overdoses. So I just want to like bring in that factor, and that it still remains the case that Black and brown communities are disproportionately affected by the overuse of opioids, overprescription, and opioid use disorders, and likewise are most affected by challenges in terms of access to services and availability of services. And so from our perspective as counseling programs, I said my area is master's level, Kevin's area is bachelor's level, and he fosters our students through their internship experiences and works with them in many other ways. But part of our responsibility is the largest share of our responsibility is making sure that we're providing counselors with what they need to know to be effective cross-culturally, and also to really invite and lift up our students and our potential students from Black and brown communities, and particularly focusing today on Latina communities, in order to, what can we do to have culturally responsive services more widely available. And I'll end by saying it's also our responsibility to be involved in advocacy and to be part of removing barriers to services, as well as trying to meet some of these profound workforce shortages. So thanks, and I will pass it along to Kevin.
Thank you so much, Dr. Libby. And I just want to say thank you so much for bringing this talent together for this conversation. I have worked in the Twin Cities area specifically for the Spanish-speaking community since the early 90s. And one of the biggest challenges that I saw was an inability to really build capacity throughout these last decades to respond to this demand that is growing just naturally in the demographics. And one of the things I'd like to point out is one of the things I noticed was just it wasn't just a lack of passion to want to provide services for the community. We needed to build internal capacity within the organizations to see the need and to be able to respond to the need. For example, developing grants and responding to funding opportunities. I would quietly over the years kind of develop this perspective that there was almost like an echo effect. There would be an announcement for funds, numerous individuals representing organizations would pursue those grants, and very often within the facilities that I worked closely with in the Spanish-speaking community, we didn't always understand how to write grants. And so that challenge that existed within some of the organizations also prevented us to respond to the capacity building that we needed. So I worked 30 years specifically in behavioral health. I see some of our participants in this conversation, people that I've worked with that are continuing to be involved in this. And so 30 years ago, I was a director in these culturally specific programs, building capacity. My background, I'm originally from Fresno, California, grew up in the same context of Dolores Huerta and Cesar Chavez. And here I was in South Minneapolis building and obtaining grants to provide first ever chronic homeless prevention, Chicano Latino Resource Center services, outpatient programming. There's a lot of truth in what has been said today, but you can see that one of the things I'm very concerned about is workforce response, workforce capacity. I am so grateful that I am at Metro State University, where we have the ability to attract this passion. People like Elizabeth, who was on our panel, who is together with us working in these efforts, connected to the community. And I heard other names, Nettie Diaz, Jose Picon, leaders. But one of the things that I continue to see is a significant shortage of licensed mental health professionals, licensed alcohol and drug counselors, so that more organizations could respond to the need. And as a matter of fact, even today, I recently helped facilitate some additional dollars, federal and state, for culturally specific efforts. And there are numerous job postings inviting individuals to apply. And the truth of the matter is we don't have enough individuals who have the credentials. So now new dollars are starting to emerge to mentor, to go to school so that you can get the job. We need more efforts like this. Again, I'm just sort of zeroing in on build capacity. I'll stop there.
Thank you, Kevin. Thank you so much. Let me bring in two more voices. First, that of Pastor Jose Antonio Machado. So good to see you. Thank you for being here. If you would, first impressions, and after you, I wanted to bring in Elizabeth Burgos. Good to see you. Thank you for being here to talk about your work and your passion. But oh, so is he not here? So we don't have Pastor Machado. Then,
I don't think so.
Okay.
Okay. We'll go straight to Elizabeth.
Okay, sure.
Yeah.
Welcome, Elizabeth.
Thank you.
Yeah, and just jump in the conversation. This is informal, and we are sort of assembling as family and as community, and lifting each other up and talking to the challenge and the solutions that we are bringing today. And I so appreciate Kevin's instruction, his examination of the critical need to bring our people into the solution side of the enterprise. But Elizabeth, you're doing that.
Yes, and I'm going to try to talk really fast before I'm having internet issues, so before I get booted off, like I have throughout, these 2 hours. My apologies. I agree. I heard Kevin when he was talking about capacity, and I know that's something that that it is a concern for me when I worked as an administrative position, and where I had to hire folks that were bilingual, that were of the community, and not having enough folks that were licensed. So it became kind of my role of kind of advocating for the field and telling folks, hey, especially if they wanted to go into mental health or different things, letting them know these are the options that you can pursue. And in terms of different schools, and I'm always telling folks about Metro State and to apply there and who to go and talk to. I know Carmen had asked me about someone that is Latino and wanted to go back to school, and I said Metro State, that's the one. Tell her to go there, just because it works with with folks that are going into a different second field, or new or untraditional students, and they provide a lot of support. Not just because I work there, but I've seen the support that they provide to the students. And I've seen a lot of, positive feedback from the students. And capacity for me is important, especially now that I have my private practice, that is just two of us. We have our third colleague, which is a business partner, but he does not speak, Spanish. It's just myself and Nettie Diaz that you guys, talked about. And now that we are looking at, we're looking at capacity building of how can we grow, because we can't do it just the two of us. We need help, and we want to hire folks. We want to mentor folks. So that has been, really difficult. And that's a struggle. that's been a struggle. So I definitely concur with what, Kevin Spalding was talking about in terms of capacity building. And also just doing a lot of education, like in a different topic of educating the community about the services available to them and being as accessible. Like we take insurance, but we also have a sliding fee scale for folks that do not have insurance and cannot pay a lot for those services, for mental health services. So we've developed a sliding fee scale just to increase access to folks that may say, you know what, if I have to choose between buying this for my family and therapy, I'm going to choose my family. So that has been something that we've seen over the years that has been helpful to make it affordable, mental health services. And I'm still here, so hey, my internet's working.
Carmen, jump in when you want to, but let me throw out some things and have all of our guests, particularly I'll start back with Dr. Morales, and also Dr. Libby. I think, Dr. Libby, you opened the door on this a little bit. What is the impact of culture? What is the impact of public perception? You said that there might have been, over time, this willingness to be ignorant of the presence of the problem. You didn't say it that way, but that's what I'm hearing, is that we had a social or societal disregard for humanity of certain elements of the population. I think that's Black and brown people. And that the questions of these elements impacting our community became relevant, it seems to me, more when they begin to impact suburban white people, housewives. Then it became an opioid crisis that the whole world paid attention to. But it seems to me there was a willingness to say, it's not us, it's them, don't worry about it, it's their problem. I have always said, this is an Al McFarlane-ism, we get the misery, they get the money. We get the misery, they get the money. Too often our misery, our problems become a system of revenue for people that are in the profession, and maybe it's not intentional, but I'm saying this is how it looks from the point of view of a skeptic, and I'm a skeptic, right? And so my question to you, Dr. Libby, is to go more into how the society, the culture, the institutions have traditionally disadvantaged people of color, and how it shows up now in the impact on our people. It shows up in the COVID-19 crisis. It shows up everywhere in all of the indicators of health. And then Dr. Morales, if you would speak to this idea of how do we change and take control from within our culture, from in the community, so that we grow doctors, we grow therapists, we grow an identity for us and for the world, that part of our cultural essence is that we are healers. And we heal in the sense that we understand that it's also business. Part of our business is our health. Our health is our business. ¿Qué piensa?
Wow. So, Mr. Mack, you tossed me kind of a big question there. So let me see what I could. So, excellent question. Let me see what I can do with it and keep it brief. So a number of years back, somehow or another, a news story from a Fox News affiliate came across my desk, and the title of the story was "The Accidental Addict." And it was telling just that story, the story of the white suburban housewife who was prescribed pain medication, and then in time became addicted to opioids and what that looks like. And I'm like, okay, let me understand what you're saying. So the poor Black person or the Latina person who gets addicted to opioids, they are intentional addicts. So is this what you're telling me? Because that's what I'm seeing when I see your headline. And so, I mean, if we were to talk very big picture, that picture's 400 years old, right? That we live inside systems of white supremacy that privilege, white people and other people with certain advantages over people of color and people without, who are economically disadvantaged and so forth. And so this has been perpetuated in the last 50 years by associating drugs with poverty, crime, violence in communities of color. Like this was deliberately undertaken in the Nixon administration, deliberately perpetuated in the Reagan and Clinton administrations. Like it's been an unfolding story for decades. So it's vital that we recognize, and that as we are, as we're training counselors and doing advocacy work, that we help other people to recognize and both look inward and look outward in terms of the role that that privilege and power have when we're talking about the effects of addiction, opioids, social determinants of health in Black and Brown communities. And so it's like this deliberate association of stigma is just really a natural outgrowth of the stigma that we have around addiction. But now when we have it associated with Black and Brown communities, then we say, it's less important, or we make bigger judgments about whose fault it is. Right? Instead of saying, oh, it's a societal problem, it's a public health problem. It's or it's a medical health problem. We say it's a moral problem. We say it's a whatever we say. Like we say all the things we say about it. I mean, gosh, there's so much more I could say, but I just think that's probably enough time for me for now.
Dr. Morales, thank you. Jump in, Dr. Morales. Unmute, please. Unmute.
So I agree with what's being said. I mean, I think it's this culture of the war on drugs that was perpetuated. I mean, it started with the Nixon era and then with the Reagan era. And there's so many people that have been incarcerated and remain in jail, people of color, that more, like almost 5 times more when they are caught with possession of marijuana to start with. So it's staggering, and I agree that quite a bit of the problem is the stigma that we have in the medical field. What we try to do is to create a sense, and we're educating about universal precautions. Okay, just like during the HIV era, where everybody was afraid to use to treat patients and who has HIV, who doesn't. And so the way with universal precautions was, okay, everybody should, no matter if they're white, Black, or whoever they are, we wear gloves, we're going to have universal precautions, a mask, and so on. So same thing when it comes to treating patients of any color, of any race. Okay, every patient who comes in should get a urine screen, should get a treatment, and treat this as a disease, not as a moral ethical problem or a racial issue. It's more of this is a mental neurobiologic disorder that we should treat using universal precautions. But it's going to be difficult to, particularly nowadays with the environment we're in, a polarized environment that we're in, to change the culture and the stigma that we have. I have patients, and I know I have a patient who, I'm not going to name, several patients who are, white and they're middle class and go to the ER, and they, back in the day, they would get whatever they wanted when it came to opiates. And these were people who had severe addiction versus somebody who was in pain and had a broken arm and wasn't really x-rayed and was sent home with Tylenol, so who was Hispanic. So that's there's multiple studies showing this and within the literature in regards to the way we treat patients, including in the physician workforce. I've even encountered that people of color, physicians of color, still are discriminating or biased against their own people. So it's a serious problem, and the only way we can help this is through education. But from a perspective of healthcare, it's treating everybody with compassion and a universal healthcare approach to everybody that we see. Another big issue is that people of color, and the study just came out. It's in the New England Journal of Medicine a couple days ago, which I have the article showing that one of the problems is that people of color have the least amount of medication-assisted treatment compared to their white peers. And when I started treating Suboxone back in 2000, when it started around 2004, 2005, most of the patients that were coming in were Caucasian. And very few people were Hispanic or African American who would come in for Suboxone. Okay, that's and I think even to this day, it's been difficult to beat that. I mean, there's patients just don't have access to medication-assisted treatment, and there's barriers. A lot of the patients don't want to go. If they're of color, well, why am I going to go to the doctor? Maybe I'll get arrested, or maybe something will happen, or they'll have some sort of stigma against me because I'm black or I'm brown, and they're going to say, well, you are Mexican, and I don't know if you're using drugs or what. So there's that in our people. There's quite a bit of stigma when I talk to them. Why didn't you come early? Well, I was afraid that somebody would, catch me with this. And so this country incarcerates more people than anyone in the world. And I think instead of incarcerating people, we should do more treatment. That's less biased.
Dr. Morales, one of the reasons that what Carmen does is so important, just the notion of jóvenes de salud, to project that idea in the community, the idea of equity, of ownership, of young people speaking to, leaning towards health and taking a sense of authorship. And so, I noticed, Dr. Morales, that, and I want you to speak to this whole idea of legacy and I say that just noting that you are the son of a renowned cancer surgeon. So you were raised in an environment that was in great service to both the profession and to humanity. And what if that could be replicated broadly? I've said that wouldn't it be awesome if there were 5,000 therapists, in St. Paul, 5,000 therapists in San Juan, people trained so that every block had a therapist or two, and all of us had the income associated with supporting others in our particular neighborhood. What would that be like, Doctor? What do you think? ¿Qué piensa usted?
Well, I think that would be the ideal. That would be unbelievable. That's something that we would look forward. I know under the president's national drug control strategy, they're looking for 2025 to kind of like the goal to get into having access like that, where we can have rural areas and minorities, and also one of the issues, what they were talking about too is trying to get low threshold for treatment, meaning that if they can't see a therapist, at least to provide some sort of harm reduction, where it means, okay, I'll give you some Suboxone for a week, or I'll give you Suboxone for a month if need be. And interestingly enough, they found out that even though I didn't know the patient and I was giving it for a month, the diversion was very little compared to, the people didn't want to give a month's supply of Suboxone because, oh my, the diversion, they're going to divert. No, they did not. And so that's called low threshold treatment. And it's one of the goals that the Biden administration has right now is for 2025, be able to have those low threshold clinics where they can come into primary care. We don't need an X waiver for treatment. And you can, hey, you've got a problem, let's give you Suboxone for, let's say it's not a month, but maybe a week, 2 weeks to get you by while we find a therapist for, because medication assisted treatment needs to be done with therapy as well. But if we can't get a behavioral health or mental health specialist, well, at least you got Suboxone that treats withdrawals and avoid overdosing and avoid mortality. That's one of the biggest goals here.
Are there models in the hemisphere that suggest different pathways or strategies for mental health and treating chemical abuse, chemical dependency? Maybe Dr. Libby or Dr. Morales or Elizabeth, maybe one of you have an idea. What's out there? What should we be looking at?
Well, there's a place, if I may add, there's a place in I know Portugal has, in Spain were two countries that were hit hard by the opiate addiction in Europe, and the mortality was high. And what they did is create a harm reduction approach, where actually clinics were giving heroin to the patient. I mean, I'm not advocating to do that here, but I think if we could give if methadone or even an oxycodone would be fine. It's like saying somebody's going through withdrawals during alcohol. Well, I'm going to have him a shot of whiskey while I can get him some treatment. Well, it seems like that reduced the mortality rate by almost 50%.
Well,
that is a very significant reduction. And the reason why it reduced is because people were getting monitored while they were giving the opioid. Heroin is just another opioid. So they were given an opioid to reduce the cravings, improve withdrawals. The only difference is that it was under a medical monitored environment where, if you're getting, and that's kind of what's been happening too with, even though doctors are no longer prescribing opioids as much because we're afraid of the DEA and losing our medical licenses, what the pandemic continues to go up and up and up. I mean, with the opiate epidemic, and that's because now patients who have pain don't have to go to the streets to get medication under non-monitored medical conditions, and then they get fentanyl or God knows what they're getting, and they overdose. So harm reduction just means an approach to say, hey, let's give you something while you get your mental health under control, and now you're in a better state to move to the next level. But at least we're keeping you alive. And we're making sure you're not getting HIV. We're making sure you're not getting hepatitis. You're not getting any other condition you can get through an IV. Very similar to what happened in exchange needles in New York in the 80s, HIV, and also for IV users.
Kevin, speak to what you talked about earlier, broadening capacity. How do we create a public will, number one, to expand capacity, to create more training, more access to training, and then at the same time, how do we, Carmen, from within our families, within our neighborhoods, like Jóvenes de Salud, increase exposure so that our children and even people in mid-career see ourselves as likely candidates for this healing work as profitable enterprise and profitable in the spiritual sense, but also in the practical and everyday sense. You get paid for doing the work of healing neighborhoods. But Kevin, what do you think first?
So resolve is a word that comes to my mind that becomes just what needs to drive us, because as Dr. Libby mentioned, there are systems in place that have worked against us. And one of the things that Metro is well equipped to do in the way we teach our courses is to be advocates while we are becoming practitioners. So I worked for many years with this construct of marginalization where I was always in a pilot program, right? It wasn't really approved. It was a limited amount of funding. And we were sort of always at the table being told, make the case, you know, and it was tiring. So that's why I say resolve. And that's why I'm so impressed with this assembly of talent, because for years we have never been like organized and holding hands and looking beyond the name of the nonprofit and being oriented to territorial kind of perspectives. We need to be resolved together across and allow ourselves to build this capacity so that numerous practitioners, numerous nonprofits come to the table. For the last 30 years, I have not seen capacity grow. For example, in Minnesota, in the 90s, we had an inpatient program through a partnership in Fountain Centers with, of course, a fragile personnel. That practitioner would take a vacation, and of course, everyone would have to work hard to see how we're going to take care of our patients while the only bilingual therapist and counselor could attend to the needs of the clients. We need to get way beyond that type of capacity. And then I just want to make one additional point. I hired therapists and counselors from Central America, South America. They were well trained. But guess what? They had to retrofit their experience into our Euro-American kind of model of substance use over here, mental health over here. Where we're going is an integrated model. And there's and one of the things that all of these therapists shared was a holistic approach to care. And here's the very important takeaway: culture-based, strength-based strategies, right? Just like we started today with music. Music and artists are the icons of culture. They're the authorities of what is truth. And in the Latino community, who doesn't know a poet? Who doesn't know a musician? And unique to their own country. That's what I mean by culture-based. The arts are incredible to include in our approach to care. And so you can hear me go full circle here when I talk about capacity building. It starts with the community. It starts with being culture-driven. It also talks about we need to be resolved to address and respond to the construct that was built that is needing to be challenged and changed.
I heard a term a few days ago that applies here. I think, Kevin, the term is culture-centric. And one of the things we might advance is this idea of culture-centric change-making or healing or engagement or education anywhere. Listen, we're out of time. This has been a wonderful, wonderful conversation. Carmen, creo que debe decir algo.
Yo quiero darle las gracias a Paulina, a Pepe Figueroa, our incredible production team that, we can't talk to people face to face, so we've had to use this machine. And we're also, Mr. Mack, we've talked about the United Nations historic decade of the African descents. And so this is part of that information that we can save for our future descendants, put it in our libraries. And so everyone who's here spending your time, thank you so much from the bottom of our hearts, because this is exactly the conversations we need. And Professor Kevin, Paulina's in Mexico and she's studying all that stuff. So I just want to thank you all so much for Mr. Mack. Yeah, what can I say? Thank you for mentioning Jóvenes de Salud. Professor Spalding knows about that. And if we could bring back people like Dr. Jose Castellanos, and all our jóvenes are men and women now, so they can really get on that team and become promotores. So thank you. Paulina, you want to?
Yes, I want to read some comments that we have here on Zoom. From Megan France. Hello, Professor Libby. Just sending a message to let you know I'm here. From Micaela Osterling. Dr. Libby, not being able to private message you, but I'm here. Also, Vicente Vasquez. And we have about what was saying Dr. Morales about Jesse Sabreda says Canada has some programs that are doing that, safe injection sites. Aaron Garcia, this has been enlightening. Gracias por todo. And we have Sky Ariole. I totally agree with Professor Kevin. Love it. Jesse Saavedra, gracias a todos. And Jim, thank you. And I want to thank everyone from your time, for being here. Thank our sponsors, DHS, ORN, Metro State University, of course, and everyone here in the panel, and the participants that were on Zoom. Thank you so much.
Thank you, Insight News, Conversaciones con McFarlane. Muchísimas gracias. So we'll get together for the next show with Machito, playing a little music. Muchísimas, Dr.
Yes, of
Morales, Dr. Libby, Professor Paulina, Pepe, thank you. All our audience, thank you. And we will follow up with information in our newsletter. So así nos terminamos, maestro. Se acabó.
Thank you.
Bye-bye.
Gracias.
Thank you so much. Have a nice day.
Don't forget Puerto Rico. We'll be doing a special show on Puerto Rico. Gracias.
Thank you.